So I'll be speaking on a little bit on peripheral ulcerative keratitis, and it's my great pleasure to be presenting this in front of my mentor and teacher, Dr. Sangwan, and also life coach and philosopher and guide, etc. I'm sure many would agree he is for many people, and it was wonderful. Dr. Sangwan, I'm sorry we were busy chatting. We didn't really listen to your oration, but we know some of its content. But we were very proud. It was a proud moment for us to see you deliver the oration. So just to go through, PUK is a very rare inflammatory condition. My talk is directed towards general ophthalmologists. So hopefully general ophthalmologists, I'm saying hopefully, won't see too much of this. So, like Dr. Sangwan says, दिमाग ज़्यादा नहीं लगाना पड़ेगा फिर. But अगर दिमाग लगाना ही है and you see these cases, then do remember that it can be either ocular alone or it can be associated with systemic autoimmune diseases. And so when it's associated with systemic disease, most of the time it can be rheumatoid arthritis, or it can be granulomatosis polyangiitis, which is Wegener's, or some of these rare diseases. And so do keep that in the back of your mind that you may be seeing a patient who has a very bad sort of a life-threatening disease. And also because the ocular manifestation may precede the systemic disease. So we may be the first persons to see the ocular manifestation. Certainly we've seen them for patients with Wegener's and so on. What's the etiopathology? Dr. Sangwan has tried his best to teach us, but we refuse to learn. But now we learn the hard way that it's both the cell-mediated and humoral immunity that's involved. And it's basically the corneal tissue that is being attacked. There are a lot of inflammatory substances that are produced by the corneal tissue, resulting in its melt. So the relevance to general ophthalmologists is that immune-mediated PUK is rare, but it's not infrequent. Similarly, Murthy's ulcer, it's rare, but not infrequent. And PUK-like lesions, yes, you'll be definitely seeing plenty of these kind of cases. I'll come to it. And remember to, again, the systemic association. Don't forget that you might be able to see those conditions as well. So what are the main causes? When it's local, you can have, maybe it's infectious, or it could be a local immune-mediated disease like Murthy's ulcer. It's a local immune-mediated disease like the picture on the top. Whereas you can also have local infections, the picture at the bottom. Systemic usually can be immune-mediated or some other diseases. The local causes includes infectious, includes non-infectious, even trauma, looking like PUK. The lids and lashes can be eroding the cornea at the inferior part, and it may look like PUK, and so on. So make sure that we look at all these other possible differential diagnoses. And of course, there's always Murthy's. In systemic causes, we mentioned about the immune-mediated, and you can also have certain skin conditions like acne rosacea, which can mimic a PUK-like condition. So these are some of the systemic infectious causes and non-infectious causes of PUK. The most important for the general ophthalmologist is to differentiate the PUK-like conditions, and there are many of those which can be inflammatory, degenerative, or it can be associated with a neoplastic or even metabolic condition. And coming to a few of them, the infectious causes, remember that HSV is a great mimicker of sort of a PUK. There was a wonderful presentation earlier where a lot of cases of HSV were discussed. We can have corneal ulcers. Even a perforated corneal ulcer can come to you and may mimic a PUK, but it's bacterial. Whereas you can have infection in a Murthy's ulcer also. So you have PUK first and secondary infection. You need to distinguish between the two. So the other mimickers are ectatic conditions. Gunjan talked about keratoconus, but you can have keratoglobus or terians, which in the periphery, when you look at the cornea, it's very thinned out. And you might say that this is resolved PUK, but it's not. It's a non-inflammatory condition like terians or even keratoglobus or PMCD sometimes. And this is yet another example of inferior terians with the scarring there, which you might think it's PUK, but it's not. Don't forget dry eye. When you have dry eye, the cornea undergoes melt, and then you might think that is also, yes, it's in the periphery, it's ulcerated, it's thinning. But look at the lustreless cornea in the fellow eye also, and you have to make sure that you don't miss out a diagnosis of keratoconjunctivitis sicca for these kind of patients. This is another patient with Sjogren's syndrome. Yes, the patient has rheumatoid arthritis, but also has severe dry eye. So it is not PUK component of the patient, but it is severe dry eye that's causing this melt. Rare mimickers, I mentioned PMCD earlier, but another rare mimicker can be OSSN. This is a patient where initially looked just like a peripheral ulcerative lesion, but later on, as the disease progressed, you could see those nodular elevated with keratin on the surface, and this was a case of OSSN. So that's all I had in 4 minutes, and thank you very much.